Good afternoon to everyone. Thank you very much for the organization for inviting me. I am Jana Dominguez. I am pediatric neurologist and I am a clinician. And I must say that I am quite new in this GRIN world, so I will try my best. And we are going to talk now about epilepsy and GRIN-related disorders. This is the outline we are going to follow in this talk. Starting by some definitions and classifications, because we need to know what are we talking about. Then we are going to try to look how epilepsy appears in GRIN-related disorders. And I will try to show you some examples of how seizures can look like. We will try to guess which diagnostic tools we have, and we will finish with some take-home messages. Well, the ELIE, that is the International League Against Epilepsy, defines an epileptic seizure as a set of signs and symptoms that are the result of an abnormal excessive or activity, neuronal activity. So, well, this is quite a broad definition. And we could say that this can include any episode with different from the basal state of the patient, that in which we can see or we can identify the beginning and the end. This could be an epileptic seizures, and here you families are crucial in identifying these episodes. But we also have to keep in mind that seizures come from brain activity, so they should be congruent with what we expect brain doing in the different regions. So this is something that we need to manage as a team, doctors and families, and I think this is really important to keep in mind. Here you have, this is the classification of seizures. We epileptologists are quite obsessed with these classifications, but they are really useful for us in terms of deciding treatments and in terms of looking for etiologies. That is not the main goal here, or in terms of setting or guessing prognosis. So this is something that we have all the time in our minds, and we go to it all the time. Well, what about epilepsy in GRIN-related disorders? As you all know, there are 4 genes that are related to neurodevelopmental disorders by now. In GRIN1, it has been described related to a neurodevelopmental disorder in which epilepsy, muscle tone abnormalities, movement disorders, and behavioral issues are characteristic features, although not all patients may experience or are going to experience all these symptoms. In terms of epilepsy, what we find here is that it usually starts in the first decade of life, with different seizure types described that can vary over time, that can evolve from one seizure type to another. And more than half of patients are going to be drug resistant. And as you can see here in the table for the classification of seizures, mainly all seizure types have been described related to this neurodevelopmental disorder. And as I said before, I will try to show you some examples after. When we come to GRIN2A, it has been described related to a more specific epilepsy syndrome. Although there is some variability as well. This epilepsy syndrome is what we called now the developmental and epileptic encephalopathies, or epileptic encephalopathy with spike and wave activation during sleep, which is a spectrum of conditions that are characterized by various combinations of cognitive, language, behavioral, and motor regression that is associated with this marked spike and wave activation during sleep, which is only an EEG pattern, but is suspected to be the cause of these symptoms. But not all the patients with this gene mutation have this form of presentation. Some of them have been described to have only what now we suspect that is part of the spectrum, that are self-limited, that is a self-limited form of epilepsy with only seizures and no developmental disorders. And sometimes this is also related to GRIN2A. And as you see in the title, sorry, speech disorders are really related to this gene, and this is because of Landau-Kleffner syndrome, which is a specific form of epileptic encephalopathy with spike and wave activation during sleep, in which we find something that is called acquired aphasia with auditory agnosia, which means that we are impaired for recognizing sounds, and this leads to a regression in speech and difficulties in processing sounds or processing verbal language and to produce verbal language. And this is again related to an excessive activity in brain during sleep. In the case of GRIN2B related neurodevelopmental disorder, what we see is a really similar picture to what we find in GRIN-A. And again, the same in GRIN2D, although here we call it, or it has been called a neurodevelopmental and epileptic encephalopathy, and this is probably related to an earlier onset that what is described for the previous genes. But in terms of seizure types, is the same. We can have mostly any seizure type. Okay, now I would like to show you some examples of seizures, because I know this is something that sometimes can be, well, quite tricky. I think here I have to say two things. The first one is that I have permission to show all the videos I'm going to show, but please don't record, don't film them now. And the second one is that what I am going to show you are not GRIN patients. So this is something that we could find in GRIN-related disorders, but these children do not have GRIN-related disorders. Well, let's start with absences. The first example I'm going to show you is a neurotypical girl with absent seizures, what we call typical absent seizures. And this is for you to see what happens. I don't know if we have sound. The girl is doing hyperventilation, and when the seizure starts, she stops hyperventilation. She stops getting her hands as she was told to do, and the nurse is telling her some numbers. And when the seizure stops, the nurse asks her about the numbers she has heard, and she heard nothing. And this is a typical absent seizures that we tend to see in neurotypical development children. Whereas in children with neurodevelopmental disorders, this is a more typical absence seizure, what we call atypical absence seizures, but are more typical for these children. Here you see a really disabled children that is moving around all the time. He has an important movement disorder, and he is moving all the time, and then he gets floppy and he stops moving. As he was in the monitoring unit, we saw that he was having a change in the brain pattern by that moment. His father noticed that something was happening. He advised to us, and then, well, and the seizure stops and the children gets moving again as he was doing before. And this is more typical in neurodevelopmental delayed children. Well, let's talk about epileptic spasms. You see that we have epileptic spasms there in all the categories. We know now that epileptic spasms can appear because of focal brain activity, but also in generalized onset seizures. And sometimes we don't have information enough to classify them. And this first one is a typical presentation of spasms. This is a sudden and brief movement, contraction of his shoulders. You don't see it, but his eyes were rolling up at the same time. And then he is going to repeat this. This is a more subtle one, and another one that is quite subtle, but then he's going to have another one that is, well, more evident. I think it comes here with that contraction of shoulders. But again, sometimes we can have spasms that are not really easy to identify, as for example, this boy was having. This here is going to come one. He was going to do a slight movement of his head to the right. Another one, you see this slight movement. Again, as I said before, as their parents know him really well, they noticed something was happening, even in his behavior, and he recognized these movements as they have seen them thousands of times. I know these are really tricky and sometimes are really difficult to recognize. But if I can give you some clues, are these 5 clues. Epileptic spasms occur in clusters. They are clusters of repetitive movements, really brief movements, and highly stereotyped. They all the time look the same. And they typically appear on awakening, on when the child is waking up. They can appear at other moments of the day, but when they wake up, there's always a cluster of spasms. And something I haven't write there is that another typical thing is that usually the first spasms of the cluster are more subtle, and then they go up. They go up in terms of intensity, and then they go down again. Well, this is a really tricky one, but I have been asked especially to show you. You know that gelastic seizures exist. I have to say that they are really rare. They are mostly always associated with a very specific disease that is hypothalamic hamartoma. But well, they exist, and although they are not the first thing we are going to have in our minds, I know that many of you have read about them, and well, you can get to think, oh, is my children or is my kid having gelastic seizures? But I am going to show you how gelastic seizures look like, and you are not going to think this again. Here, I really need a sound, so hopefully you can hear her. Well, this is a really atypical laugh. This is not normal. This nothing's happening to make her laugh, and this is really different from when this little girl laughed because she was enjoying something, or she was having fun. So these seizures are well really easy to recognize for you families that know your children. Another tricky one are behavioral, what I have said there, behavioral non-paroxysmal epileptic, behavioral non-epileptic paroxysmal episodes, which are more frequent than what they can look like that are hyperkinetic focal onset seizures. Well, in neurodevelopmental disabled children, these can be difficult to recognize, but these are by far much more frequent being non-epileptic episodes than being seizures. I will show you seizures, non-epileptic, not non-epileptic episodes, but this is just for you to see how they look like, and they are, well, again, really different from what this in this case this boy did. For example, these like cycling movements with the legs are really typical for frontal lobe seizures, and well, for epileptologists with experience, are quite easy to recognize. Although I know that this is a really weird episode, but well, for someone who has seen these episodes before, it's really easy to recognize that this is a seizure, a frontal lobe seizure. But sometimes there are even more tricky, as for example, this little girl's movements. You will see that she will, well, wake up, or the seizure is starting, and she starts doing this, well, like chaotic movements. She does like a lot of movements with her arms, like setting her hair. You don't see her face, but she looked like being really in panic. These are usually brief episodes, not lasting not more than 1 minute, usually, or really typical during the night, although they can appear as well while awake. And then, well, that's stopped, and she will get back to sleep. I know this one is really, really tricky, but I will say you in a bit later some clues again. Okay, so what can we do to diagnose or to see if something that a child is having is a seizure or not? The most useful tool is the medical history. Is by far the most useful diagnostic tool when dealing with a patient with an epileptic seizure. We need to obtain an accurate, thorough, and detailed description of the episode. So we are going to ask you once and again what happened, and what happened then, and what happened then, and going back to the beginning, and what was the kid looking to the front, or to the right, or to the left, or his head was going anywhere, or his arms were symmetric or asymmetrical. These are things that gives us a lot of information. So we are going to be, well, really obsessive in getting this information. And if we have videos of the episodes, this is going to be even better. So I encourage you to take your phones out and video and film your kids. I know sometimes it's difficult. They are suffering. We are completely in an anxiety situation. But if you and the first thing is to keep the children safe. But if you can, I encourage you to film them, because this is really useful for us. For example, as I show you, this is again this little girl. I promise these are these four are all different episodes. This little girl had more than 45 episodes that night. But as you can see there, she is doing every time exactly the same. The pattern is exactly the same. I know what she is going to do second by second. And these highly stereotyped features on these seizures, on these episodes, can be nothing else but seizures. If something is so stereotyped, this is really possible to be seizures, epileptic seizures. And what about the EEG? We are talking about epilepsy, and I have said no word yet about the EEG. Well, this is because EEG could have two phases in terms of clinics. The ICTAL EEG is the gold standard diagnostic tool for the diagnosis of paroxysmal disorders and epilepsy. This is nothing. There's nothing better than this. But most of times we are not going to get to capture the episode when we do a 30 minutes EEG, for example. And when we only get an interictal EEG, this could even be a confounding factor. So if I have to choose between an interictal EEG and a home video, I prefer the home video record. Although, of course, there are some moments or some episodes in which this differential diagnosis is really, really tricky. And in those cases, well, if you can get to a monitoring unit, and we can perform a 24, 48 hours EEG, this is going to be, and capture the episodes, this is going to be the gold standard. And just to finish, some take-home messages. Well, epilepsy in children with GRIN-related disorders can present in different forms. There is no specific phenotype, and seizures can change over time. We could say that any set of symptoms and signs that appears suddenly with an identifiable beginning and end could be an epileptic seizure, but we need to keep in mind that they should be coming from the brain. So they should be congruent with what any different part of the brain does. And medical history is the most useful diagnostic tool when dealing with a patient with an epileptic seizure, but home videos are a very, very powerful tool, as they can demonstrate stereotyped episodes or show previously unidentified signs. And when doubts persist, prolonged video EEG monitoring or an ictal EEG, if we are lucky and we can do it in a shorter EEG, is the gold standard for the differential diagnosis of paroxysmal episodes and seizures. And that's all. Thank you very much.